Yeah, hi, I'm Jake Botfield, National Specialist from Aspire Healthcare. Thank you for the session this morning. It's been really provoking and some really positive sessions. I think my question was for John. You mentioned when you did that significant change programme that education was a key part that you came across. Do you think you could have delivered that change without that education element, or was that quite crucial to the management that you were successful in delivering?
Education was absolutely important. I don't think it would have happened consistently without it. It's also being able to take time with the nurses and saying, this is why we want this change, rather than just saying, this is a change, this is what you've got to do. Because we found staff brought into it a lot easier, and they understood what the ask was. So yeah, it wouldn't have worked without the education input.
Yeah. And if I could just add to that, I think, if we think about behavior change strategies, so your behavior that you wanted to change there was for them to complete the screening tool, right? So that's the behavior. There's something called the COM-B model, so capabilities, opportunities, and motivation. Capabilities that people know what they need to do. That's how you can use education for that. So if they don't know, you said they don't even know what they need to do. So you could have a policy, but if they don't know what they need to do or how to do it, then it's not going to work. That's the capability. Opportunities, that they have the opportunity to do something. So you have the screening tool ready. The medics had already told you that they need it as an electronic version, but maybe because they didn't have the education or something else may have worked for them, the opportunity was there. So no behavior change. And then the motivation is that people want to do what's right. As clinicians, as medics, we're all clinicians, we're working with in a clinical setting, then we're motivated to do what's right for the patient. So actually what you've done there is the C part, the capability, which is the education. So thank you. Okay, question at the back.
Hello, my name's Pete. I'm a critical care and outreach charge nurse from the Royal Derby. My question again, unfortunately, is to John, who seems to be picking up a lot. I'm amazingly impressed by the increase in the use of the sepsis screening tool. Have you noticed a reduction in admissions to ITU with sepsis or overall mortality through the trust for sepsis?
So I can't answer the ICU question because that's one part I'm not involved in. Unfortunately, we have seen an increase in our mortality within our trust, but it's in line with the increase nationally as well. And also we've looked at a lot of the external factors that have driven the incidence of sepsis. So our trust sits in a highly deprived area with lots of comorbidities, lots of frailty. So we have very high risks for incidence of sepsis. But I feel that we have seen a reduction in the investigations that we've had to perform around sepsis when we've not got it right. So I do feel that we are moving in the right direction.
That's really interesting, actually, because that was one of my questions as well, is what's the outcome. But I think that point you make around the reduction in investigations means that actually patients are being appropriately managed. And so the health inequalities one is probably a theme that many of the speakers will hear me talk about today, because I think we need to consider that as well as, and so whilst people have increased risks, which of those are modifiable, and what can we do within the healthcare setting to mitigate against those?
Hi, I'm Andy Ison. I'm one of the ED consultants at Blackpool Victoria Hospital. Mm-hmm. Hi, Melissa.
Hi.
Really enjoyed your talk. Really interesting about MED BV. I don't know how you say it so quickly. I obviously see a lot of trauma and atraumatic patients within the ED, and I'm just looking at the figures that you've put forward. I just wondered if there was any sort of exclusion sort of criteria in trying to differentiate bacterial and viral illness in people such as our neck of femur patients who've obviously had a bit of a tumble and a fall that we see in the ED, and how does that impact on the sort of result?
Yeah, so there are no exclusions, but there are limitations because they weren't able to study every single scenario in which you would want to differentiate between bacterial and viral infection. So one of the limitations is trauma, so that you would have to kind of use your discretion and kind of assess the likelihood that the trauma was such that it would in fact, their host response in that way. So it would just depend.
Sure.
But we are working on expanding all of the different scenarios. Now that it's in real-world practice, it's a lot easier to start understanding how these scores play out with a lot of different populations. One of the other big lookouts is for pregnant patients. So again, it's been used. We see different scores popping up, so it's not like you end up with everybody getting a 0 or a 100, but then how that plays out in sort of the middle range is an area of caution. And then patients with active chemotherapy is kind of the other big lookout. But as I said, keep your eye on the literature. We are publishing rapidly, several papers, probably every quarter. So there'll be a lot more coming out.
Thank you.
Thanks.
Thank you.
Can I be cheeky and ask another question?
For Melissa or something?
It's Tom.
Okay, go.
Yeah. John's been picked on, I think.
For Tom, yes,
yeah.
yes, for Tom.
Hi, Tom. Hi. Really enjoyed your talk as well. Just a very quick question about procalcitonin. We obviously hand our patients over to ICU, sometimes requiring inotropes, et cetera, it's at that stage that the patients often start getting procalcitonins in ICU, where we usually use the usual CRP markers in ED to help obviously differentiate that sort of element of inflammation that's going on. Should we be taking procalcitonins with our CRPs at the outset when we have like a new score of 3, 5, or the patient's unwell? Or do you think that's something that actually can be sort of delayed until the ICU referral's done, they're on ICU, et cetera, et cetera, et cetera? When would be the best time, would you recommend?
Good question. So if your hospital is a hospital that does use PCT, because it's very variable around the country, so if your ICU, for example, do use PCT as part of their decision around duration, then actually, yes, it would be helpful for you to get that baseline as early as possible. It's a major problem in the trials as to how quickly you can get your PCT, because the baseline number is really important to get that kind of proportional drop. So yes, I think it would be beneficial if that's how it's been run in your hospital. In my hospital, for example,
Yeah, it is, yeah.
PCT is just done completely randomly, and so it's not very helpful if someone just does a PCT on day 3 and they're like, well, it's hard to know how to use that. But if it's regularly being used in your hospital, then PCT at baseline would be very helpful.
Thank you very much.
Thank you. I'll take the question for John now. Thank you.
Hello, I'm Marius. I'm a consultant in the emergency department in Doncaster. And I've actually got a 2-part question for John and 1 question for Peter, if you don't mind.
3 questions,
Yes.
no problem.
So, for John, have you done this in ED? So your trial, your quick.
We haven't done it in ED as such because the problem we find was we needed the observations to be recorded electronically so that I could remote review those. And our ED is literally only just moved over onto electronic. So we didn't do the program in ED, but we did do the education program, and that continues. We do a session every month with ED staff.
Thank you. And then the second part was, have you looked at correctness of sepsis screening, or just the screening itself?
We've just looked at the sepsis screening itself, because obviously we use it as the pathway in escalation, and we're saying this could be sepsis. So that's the approach that we have been taking, and we've also found it really useful for new registrants who have come back to us and said, we really like this guidance that we know that we can do, and we can say, right, I think it's this, I would like you to come and review, and new registrants particularly really do like that guidance.
Can I just build on that one? And how have those who are the next phase? So I think you said nurses are doing the screening, and then they go to the medics or anyone who's a prescriber, I'm assuming.
Yeah.
How have they felt in that? If they felt an increase in being asked to review patients, or increase in workload? Any qualitative feedback?
So, again, unfortunately, we do have an issue within our trust. We use the alertive system, but everything gets as an urgency
Okay.
to the medic. So even if it's, can you prescribe me something, or this patient may have sepsis, everything comes to as an urgent. So that's something, again, that we're looking at. But the clinicians have brought into it really well. And what we have also found, we just looked at this for the first time from the sepsis audit, is we found that most of our delays happen on that night shift when there's less staff around.
Okay. No, thank you. Okay, you had one more question, yes, please.
Yes, I did have a question for Peter. So when it comes to the high-risk septic patient, I do appreciate that in the community they're not using news, but the paramedics do use news. Have you seen from sort of NICE any sort of onus on sort of community and paramedics trying to start treatment in the community? Because we know they get delayed. So when I see them, they've already beyond the 1 hour gold standard. Have you seen any action on the ground?
So in terms of the early warning scores, we've had anecdotes that ambulance services are asking GPs for a news score rather than a traffic light trigger. So that's certainly true. But there's no published evidence I'm aware of that suggests that's happening. But my personal view is that over time, as news becomes more embedded in both hospital ambulance services, that will then creep over to general practice. We'll also hopefully get some data about news use in community settings that is coming now. So I think it will change. I don't think that the news score or the early warning score itself leads to delays in the system. I'm not aware of any evidence for that happens.
Are there any other questions? Yep, there's one of them. Whilst we're on the way there, can I just quickly ask Peter, in terms of what would you like clinicians to do? If there's one thing that you'd want to happen in clinical practice as a result of this NICE guidelines, what would it be?
Well, the problem is there's always more than one thing, isn't there?
I know.
And it depends.
Okay, two.
And it depends. Well, it depends who you are.
Okay.
I think.
So our audience here.
The most important thing for me is the bit that appears in front of every NICE guidance that says NICE guidance represents best practice according to the evidence we've reviewed, but it does not take over from your clinical responsibility and use your clinical judgment for that particular patient in that particular circumstance. And it's the maintenance of clinical judgment that I think is important. NICE guidance is a tool, it's not a Bible.
I like that. Actually, you managed to get into one. So that is, and that actually applies to all NICE guidelines. So thank you for that. That's really helpful. Okay, do we have, yep, thank you.
Sorry, it's for Peter as well.
That's
great.
great.
My name's Anne, used to be a sepsis nurse and I'm now working in research. And it was just about, I was really pleased to see the inclusion of people with a learning disability in the latest version. I know it said people with learning difficulties in an earlier version of NG253. But just wondered what evidence you use to support assess people with extra care, because having asked some people, it doesn't mean a great deal of specifics to people of how that's different from assessing other patients.
I think there's actually very good evidence that people with learning difficulties have early mortality, have reduced life expectancy, and that their response to they're more at risk from either escalation of care and having to go to ICU or mortality from sepsis. The reasons are less clear. Some of them may be due to the underlying comorbidities they have, along with the learning difficulties. Some of them may be due to difficulties in communication. I suspect that's a large part of it. People with learning disabilities are unable or may be unable to express their symptoms so much. They may be relying on carers and supporters to advocate for them. It's easier to ignore them. So I think there is good evidence that people in learning difficulties
are more at risk from sepsis and should be considered more carefully?
I can add to that because I think that one of the research I was involved in with the University of Manchester may have had an influence there. So we analysed open safely data, primary care data, to look at clinical risk factors as well as areas of health inequalities or factors normally associated with health inequalities. And one of the things that we did find was about those with learning difficulties. Obviously, that's been identified in other areas before, so it wasn't the first time, but we were there was a national guidance which was published that didn't include anything about factors associated with health inequalities post-COVID. And so then there was the assessment to look at primary care data. Because prior to that, all we had was systematic reviews, and most of it was information from US and other parts where the health system is different. So it was the first time we were analysing England data, at 19 million patient data using Open Safely. And that revealed quite a lot of what we suspected, but we didn't have data to show it. And so that was the first time. And University of Manchester and UKHSA did that project together. I went through press release, and the amount of uptake that it was taken by the press because of the first time and the importance of the information. So it wasn't just factors, it was things like learning disabilities as well as other comorbidities. And also the number of times a patient might have had antibiotics, for example.